First of all, I would like to thank Dr. D. Shaputra and head of program Randy Indre Anti for your hospitality for me to have this opportunity give a lecture to students and faculty in your prestige biology program today. Also, I would like to appreciate Ms. Sri Rahayu for her arrangement making today's webinar lecture possible. Again, thanks for all you to be present my lecture in the early morning on Friday. First, in the beginning of my talk, I would like to briefly introduce my expertise in the past by using intravital microscopy plus transgenic sickle mice to unblind the pathomolecular mechanism of sickle vessel occlusion, underline the heterotypic interaction among endothelial cells, white cells, and the red sickle cells in the venue. In the movie clips, it demonstrates that a past capillary was near to be occluded by the hidden white cells and the sickle cells. You can see the elongated sickle cells in the bloodstream. And it turned out a new paradigm in which leukocyte play important role, mediate the capture free erythrocytes in the bloodstream during the sickle crisis. This study turned me onto the study in the biology of neutrophils later on my research career. And there are two main goals in this presentation. The first one is to characterize the molecular mechanism of the disease, and the second is to introduce the putative therapeutic agent and the preventive regimen to cure this disease, coupled with increased survival rate of patients. Hopefully, we learn from the lesson dealing with the Sars Cov2 virus and be ready for next infectious pathogens in the future. Now, the slide today's presentation will outline content. This slide outline three contents of the contents, including 5 categories. The first one is COVID-19 statistic of COVID-19 pandemics, including mortality rate among the different countries and impacts on economics, in industry sector, and education. The third one we will report some industries will benefit from the COVID-19. And second category, I would like to go over the detail of this virus. Okay, and in the first part, I will tell you how to identify this particular coronavirus, and then I will report what kind of mechanism or way to transmit this disease and what symptom the patient will appear and what kind of diagnosis methods will apply during the finding this disease in patient. And that the last part in this category, I would like to go over detailed structure, genetic information regarding this virus and what's the life cycle, how to make infection in the patients. The third part, I would like to go to the immune response on the SARS-CoV-2. And this will show you how COVID-2 virus bind to ACE2 receptor and leading to imbalance of RAAS system. Okay, and second one, I'm going to introduce the ARDS, which is usually developed in the COVID-19 patients, okay, and leading to mortality or death of patient. And third one, would I go over the immune response and the cytokine storm and thromboinflammation. Those factors or parameters will contribute to the progression of patient suffering COVID-19. Okay, and last, the first part I would like to go over the drug for the treatment and the vaccine. We would like to compare the vaccine, how to prevent the COVID-19. And last part, I will go over very shortly, probably 2 or 3 minutes, to introduce TMU and my department. Thank you. Okay, I'm going to use this chart to go over the early beginning of the COVID-19 outbreak. Okay, that is, this chart represents the last 2 months. Okay, and a lot of events happened in these first 2 months. And the patient was diagnosed with the symptom of Wuhan COVID-19 on December 8, 2019. And you can see that less than 2 months, on June 29, it has been reported death toll climbed to 132, and 600 new cases were reported. And this suggesting this new virus are very powerful, very effective to transmit from the person to the person. Okay, and you can see that around maybe 1 month, the first death in China was recorded and reported, and 2 days later, it has been reported a similar case outside of China, and was reported in Thailand. Okay, and 23 this day is a day to lock down the Wuhan city without no rail, no bus, no air service in and out of city. Okay, and this strategy making it turned out the situation better in China. Okay, prevent a disease spreading into other major city in China. Okay, I'm going to use this chart to show you the Southeast Asian country, what's their performance during the COVID-19 pandemic. Okay, let's look at those countries: Philippines, Thailand, Vietnam, Malaysia, Singapore. You can see there has a mortality rate around 2.1 or 0.3, 0.4 in Vietnam, 0.4 in Malaysia. Okay, Singapore is 0 fatality %. And Indonesia has a higher 2.7. And okay, this number is above average mortality rate comparing to other countries. Okay, and it's demonstrated that the country in this region perform pretty well comparing to India, comparing to India, comparing to Australia, and comparing to New Zealand. Okay, especially India, you see a lot of people suffering this kind of disease. Due to the experience of SARS, Taiwan, Hong Kong, and Vietnam, they have some experience, though they put a lot of good policy to prevent this disease in the onset of COVID-19 outbreak. We put a lot of we encourage people to put on a mask. We guarantee for the people traveling from overseas at 2 weeks in the quarantine hotels. In this way, put our society much safer. Okay, and minimize the disease, minimize the death rate. Okay, I think this is a very successful part from my point of view. Okay, this data was derived from was derived from WHO on March 9, 2021. It has been reported near 117 million people confirmed this acquire this disease. Among them, there are more than 2.6 million die of COVID-19. Okay, and this number suggests that 1.5% of population on Earth contracted COVID-19, and the mortality rate is equal to 2.2 at the at March 9th, 2021. Okay, and it suggests then, and this suggests that we still cannot find the end of this disease yet. So the best way to prevent or stop the disease spreading, the most powerful way is to give the individual with a vaccine. However, only 3.4% of population receive the vaccine. So there's still a lot of work to do. Okay, I think the people, the country should share vaccine to most the developing country, okay, in the future. Here is the list. Several countries has above average fatality rate of death rate. For example, like Mexico, Peru, Hungary, South Africa, Italy, United Kingdom, Germany, Indonesia, and Colombia, Poland, and Slovakia, and Argentina, Brazil, which they has more than 2.2 death rate when people suffering COVID-19. And this is very complicated number regarding the mortality rate. It's associated with the people suffering this disease, total population suffering this disease, and also correlate to public health and education, and also associated with the availability of medical resource. Okay, so it's very complicated issue. And let's see this chart. On the onset of COVID-19, you can see the stock market, no matter in the Japan, in China, United States, Europe, Italy, they drop very, very fast. Okay, and very quick, and they may drop more than 30%, some more than 30%, some go to the 20%. Okay, and it has been calculated the G20 economics fell 3.4% year on year in the first 3 months of the 2020. Until the January of this year, some stock market are recovered, especially in the Japan and China and Wall Street, United States. However, Europe stock market still on the way to recover. And in the beginning of COVID-19, there are two major industry sector affected most severe. The first one is aerospace and the defense, and the defense. Another one is the transportation, airplane, and the traveling tourism. So far, they are still hit, so the impact is still so huge. Okay, and later on they are eventually recover. Okay, and some countries suffer a lot unemployment rate during this crisis. They increase a lot. There are two major countries. One is Canada, another one United States. The unemployment rate it increased from 5.7 to 9.7%. Only more than 4% increase. United States more than 5% increase. Okay, the impact is so huge. And the other country also, for example, Brazil, Italy, United Kingdom also has significant increase in employment rate. And due to the economic impact and the unemployment rate increase, you can see a lot of countries like Canada and Europe, Great Britain also suffering in recession right now. The only one country has GDP increase was in China around 2. You can see that here is 2%, around 2.5% here. Okay. And here, this chart show you the number of commercial flights. Okay, here as you can see that on 2019 is very stable. The total flight number from each month around 100,000. Okay, between 100,000 and 125,000 per month. I mean the flight numbers. However, after the onset of COVID-19, it dropped less than 25,000 commercial flight per month. Okay, and it climbed a little bit until now, still less than 25,000 commercial flight a month. Okay, so it's suggesting traveling tourism is still suffer and harmful due to the COVID-19. And here's the industry of tourism. For example, Brazil and the United States, Thailand, Indonesia also suffering. For example, here maybe around 50% to 30% tourism. Okay. And according to ESCO, over 1 billion children in 86 countries were bound to learn from home due to the COVID-19 because of school closure. That's the reason why now Zoom, this software, is so popular. So many software are used during the online lecture or online meeting, which will change the way for education. And however, some teacher is disappointment regarding online teacher. They feel the short ineffectiveness in instruction during the lecture online course. Okay, and but however, there are another a turning point for the shopping, for the business. For example, in shopping, people enjoy the shopping during the COVID-19. They don't go to the mall. They don't go to the shopping center. They purchase their products through the phone, through the pad, or through the computers. Okay, you can see more. You can see the Germany, it dropped almost 100% the shopping at home. Okay, so the COVID-19 changed the shopping behavior significantly, and another business, e-commerce, was increased. For example, there are 35% increase by e-commerce, online shopping to get their food, get their drink, alcohol. Okay, and during the COVID-19 also increased 50.8% purchase on their online personal care and the beauty sales through the online, not the retail store. And of course, pharmaceutical company will benefit from COVID-19. A lot of different pharmaceutical company, they will develop their drug, they developed the vaccine. Okay, so you can see their share value increase since 2019, almost, from almost almost 200 times. Okay, more than 200 times. All this suggests COVID-19 impact our human society so huge in economics, in the way in education, receive education, in the way, in the behavior, in the business, okay, in the way, in the transportation. Okay, so the impact is huge. Okay, the next one, I'm gonna go over what is the first to find out what is the agent for cause the COVID-19. Okay, the first identify or new type of coronavirus or the agent cause the COVID-19 was observed, was discovered on the January 7, 2020. Okay, this is probably 1 month later since the first symptom was discovered, okay, in the Wuhan city. Okay, so let's look at what it looked like of coronavirus. And this sample, this image was taken from the TEM, and sample was derived from bronchoalveolar lavage fluid from the patient, okay, and also in the tissue. You can see that that's a virus, a co-protein and protein envelope covered with a lot of spike on the edge here. There are two viruses in this image. Okay, and look at the tissue, you can see a lot of a dense dark particle in the endosome, in the cytoplasm or host cells. This is the first image to tell you this infectious passenger belong to the coronavirus, okay, by their morphology. Later on, the scientists grow those viruses into the cells, host cell in vitro, and observing their budding, observing their life cycles. Okay, that's first the image show how coronavirus replicate in the cells. Here it is a lab steps. The virus get out from the cells by budding. You can see some of virus use exocytosis with the fusion membrane between the cell membrane and virus membrane, and budding out to the, for example, here out to the cell, host cells. Okay, and here you can see very clearly a lot of spike, okay, surrounding the body of the virus. Here is another image, okay, the blue color coronavirus exists in the cytoplasm. Here, believe is endosome. Okay, and this picture was intensified and modified by those electronic image. The image from TEM or SCM. You can see a lot of spike stick out from the core protein or Kovind, Sars Cov2 virus. Okay, and we use another film, another picture used taken from the SCM. You can see that we observed after virus infection at the 2 and 48 hours. You can see the changes in morphology of host cells. Cells is growing to the pseudopodia structure, spike structure from the cells. And later on, you can see a lot of budding progenies of the virus are budding out from those pseudopodia structure or line structure. Okay, and this picture in the right hand side, you can see that a lot budding virus show up on the cell surface here, and they show you the size probably 400 probably around 80 probably around 200 nano, okay, in the size. And here you can see the D and the E, you can see the budding structure. So it suggests the exocytosis and the endocytosis is the way virus get into the host cells or out or free outer cells. Okay, here's the endosome. Okay, this picture show you this whole, as you mentioned previously, the host cells were growing like a tentacles shape, and this we believe that it can help SARS-CoV-2 virus budding from this pseudopodia structure here. Okay. Okay, we use several images from the SCM and TM and tell you information, tell you the shape, tell you the morphology, okay, and tell you the way how to get into infection, how to release their progeny of virus in outside the tissue from the cells, okay, and so according to their morphology, we are so sure it's coronavirus, one of coronavirus. Here, I would like to report it at least 7 different kind of coronavirus were observed in the past. 4 of them are human coronavirus. 3 of them are zoonotic coronavirus. In other words, they can survive in the animals. Also, they can pass from animals to the human and cause the severe disease. Okay, let's look at the 4 human coronavirus: 229E, NO63, OC43, and the HKU1. Those viruses did not have a strong impact on the human disease. The symptoms look like a flu virus. Okay, and so far there's no case reported, no death reports. Okay, like a common cold, their symptoms. However, zoonotic coronavirus, so far there are 3 types has been reported and caused a lot of fatality in the past. The first one is SARS-CoV virus, has been discovered on 2002, and another one is the MERS-CoV was discovered in 2013. And last one is COVID-19. Okay, and you can see these 3 zoonotic coronavirus will cause a pandemic, will cause human severe disease. You can see that the SARS-CoV the outbreak was occurred between 2002 and 2003. It has been confirmed more than 8,000 cases and 774 deaths, and the death rate is around 9.56%. And MERS-CoV virus, it has been documented that more than 2,500 cases were reported, and fatality rate is highest among the coronavirus, is 35%. Okay, and the COVID-19 since December 8th till today, there's has been reported around 20. This number is old data, so it's, but however, the fatality rate is very close, 2.27%. Okay. So what's the major difference between these 3 coronavirus? Okay, and what's the similarity and the difference between those coronavirus? Okay, we can see that we believe that all the 3 zoonotic coronavirus are derived from the original host, that's the bat. Okay, bat is not clean animal. Okay, and later on will transmit to another intermediate host. For MERS, they stay in the camel, and for the SARS-CoV, they believe in the civet cat. And however, for the COVID-19, right now still unclear, but some people suggest maybe it's a pangolin. Okay, and the way that it passed from the intermediate host to to human still not that clear, and believe may be derived from the fluid, from mucus, from diet, from direct contact. Okay, still not clear, especially Sars Cov2, COVID-19 virus. The way they transmit from the one person to the person cause the pandemic or trouble in community. We believe there are three pathways, 3 ways. The first one is droplet, which the droplet, the size probably more than 5 micron. If the droplet of virus is very tiny, they go with the air, we call them aerosol, airborne transmission. And third one is contact transmission, okay? So that's why the best way to prevent community transmission is to protect yourself and put on your mask, okay? That's very important to prevent, to make sure your safety. And wash your hand routinely. I would like to report you one case in Taiwan. They are significant dropped and save a lot of insurance due to the hobby and the regulation. With school children need to put on mask in the lecture in the school, and they need to wash your hand between the lecture, between the class. So there are very, very few cases the winter flu cases has been reported in Taiwan. So it's much safer in campus comparing to before the COVID-19. Children did not suffer flu virus or stomach virus in the past years. And this slide to show you what's the common sign or symptom, okay? And the symptoms, a patient will develop the fever, headache, runny nose, sore throat, coughing, okay, sputum. Some people will express breathing difficulties. However, some people without the symptoms, and some people will develop severe symptoms with a high fever and have trouble in breathing and pneumonia, and sometimes will develop ARDS and kidney failure, okay? Compare the symptom between the flu and influenza virus and common flu and with the flu zoonotic coronavirus. They are very, very, very similar, okay? And their incubation time, period time, is about 2 to 14 days. That's the reason why the Taiwan government put the quarantine time or stayed in the hotel for 14 days. Okay, that's a minimum requirement for people traveling from overseas to Taiwan. Okay, to make sure we got a clean and safe environment in Taiwan society. Okay, here the symptom is very similar with the flu, with the influenza virus infection. Okay, after the okay, another way when the you want to make sure the patient was COVID-19 positive or not, we are going to do diagnosis and the testing. There are 3 ways we can perform. The first one, we get sample from nostril or throat, use the swab and put into the PCR machine, okay, to amplify, to searching and amplify viral in the genome. Okay, it will take probably around a couple hours to the days, probably 12 hours or 7 hours, I believe. and it costs a lot, but it's very sensitive and very specific. Okay, their PCR methods is, we call them LAMP, is loop mediated isothermal amplification. It's very fast, it's increased in sensitivity and specificity. Okay, they apply 4 to 6 primer to amplify the particular genome or viral RNA. In the end, will cause a lot of looping structure. And in this LAMP, they add a very unique enzyme, RNA dependent enzyme, reverse transcriptase enzyme, which is very heat stable enzyme, can work in on around 65 degrees. So during the PCR cycle, they don't need to do separating annealing of a DNA or RNA. Okay, so they can work all the time. So you don't spend in the time for the denature annealing of genomic material. So you can save a lot of time. And also because of high temperature, so will provide more accuracy during the PCR. Okay, during the PCR. The second one, we can double check the expression in the serum or blood from the individual. Did they show any antigen or the virus? Okay, using ELISA. Okay, again, we get the sample from nostril or throat using a cotton swab. Okay, and put into the cartridge. Okay, double check it. So it's very fast. Okay, but it has a limitation, which when the titer of virus are low in the individual, it's very hard to detect. Okay, another one, check the antibody production in the patient. Then this way cannot tell you are under infection or not, because it just tell you got an antibody and only tell you one true story. You had antibody already. You probably has been infected before. Okay. And what's the fee for paid the COVID-19 test? In Taiwan, probably around 7,000 NT, and probably around the 3.5 million rupee, I guess, in Indonesia dollar, I guess. Okay, for United States, probably costs around 250 US dollars, and in British United Kingdom, probably around $130 to $200. Depends on what kind of methodology you use. Okay, and in Japan, probably around 25,000 and 50,000 yen, probably around very similar price to the Taiwan, around 7,000 to the $14,000 in the expense for do COVID-19 test. Okay, and furthermore, you want to do an advanced check or diagnosis of COVID-19, you can use chest X-ray to analyze. And for example, in the figure 8, it show healthy patient without any without any symptoms. But in the figure B, you can see a lot of white spot on the lung. We call them bilateral opacities. Okay, in this lung tissue on a pulmonary tissue. And you can also use the chest computed tomography, CCT, to give the more detailed information, okay, for diagnosis. So we go over the structure, we go over the diagnosis. Now we are going to give more detailed information regarding the structure of SARS-CoV-2, this virus. Okay, you can see that the genetic material is a single messenger RNA. This RNA is a positive sense RNA genome. In other words, it can use this RNA as the blueprint to start to do translations. Okay, and they are going to use RNA-dependent RNA to transcribe to minus on a negative sense RNA, then convert to positive sense RNA for future packaging to produce more pathogenic virus. Okay, and its genome probably around, the size of genome is around 27 to 32 kb, and it can code in 9,860 amino acids. Okay, beside that, we can see has a four kind of different major protein. The first one is a nucleic capsid phosphoprotein. The short name is we call it M. Another one is a membrane protein. Another one is an envelope protein. And the most important protein is spike. And the short name is S, which is very important for binding or receptor ACE2 in host cells. Sorry, there's a short difficulties in play the PowerPoints. Okay, let's compare the genome among the three coronavirus. Okay, first one is COVID-2, COVID-19 virus here, and the next one is a SARS virus, and this is a MERS virus. You can see that they share very similar RNA structure. Okay, and they share very high homology in the 5' end and different in the 3' end. The major difference is the envelope protein here. Okay, with the different envelope protein sequence among the three coronavirus. And however, SARS and the COVID-19 virus has more than 50% homology, and the MERS has less homology comparing to other two type of coronavirus. Okay, let's look at the spike. Let's look at the spike protein, because this is the main actor of this slide, this presentation. You can spike protein has a composed of trimer protein, including triprotein has a S1 domain and a S2 domain. Okay. S1 domain is contain a receptor binding domain which can recognize ACE2 angiotensin converting enzyme located on the host cell membrane. Okay, it's a binding site between the neuron, between the virus and the cells. Okay, and S2 including the two domain as S1 region, S2 region, compare another two domain, HR1 domain, HR2 domain. The S2 is very important for fusion between the membrane of virus and the membrane of cell of host cells. Okay, here during the receptor binding, they use the S1 region, which has a receptor binding site. And in this binding affinity is not that high, it's intermediate state. However, if the S2 domain with contact with the membrane and with the sister or with the assistance of the protease TMPRSS2, this protein will help them to do a fusion, then will release this co-protein the viral protein into the cytoplasma. So it's very important for cell vision. So I would like to emphasize these two events. First one, ACE2 receptor. Another one, this protease TMPRSS2, which are very, very important for facilitate entrance of the virus COVID-19 into the host cells. I have trouble. Okay, here we're going to introduce the life cycle of SARS-CoV-2 in host cells. You can see that virus entry by means of the ACE2 receptor and also with the S spike protein. Okay, and use the endocytosis the pathway loading the virus into the endosome. In the endosome, they contain a lot of different enzymes under a lower pH value of environment, low pH environment. Okay, will activate those proteases, which will disintegrate or protein, co-protein, E-protein, membrane protein, eventually will expose their genome. A positive sense RNA. Okay, and then positive RNA will coding to their messenger RNA and go to the translation into their protein, and also they will replicate themselves. Eventually, they will do the assembly. Okay, and will budding and release out to the cells through the exocytosis pathway. That's their life cycles. So in other words, those virus did not carry anything except the genome RNA. So they need to hijack all the enzymes, energy resource in the host cells, provide them to do translation, transcription, and assembly. Okay, so this signaling later on we are going to tell you will cause cell death. Okay, and due to a lot of viral progeny released from the cells and will integrate, impairing the membrane integrity and cause cell death due to release a lot of cytoplasmic contents. Okay. Okay, since the SARS-CoV-2 infection was successful setup, will cause two major pathophysiological events. The first one, of course, will give the alarm to induce severe immune response. This will cover both immune system. First one is innate immunity, and the second one is adaptive immunity. Innate immunity including neutrophils, basal eosin, and the macrophage monocytes. Okay, and adaptive immunity including B cells and active form of B cell plasma cells and T cells, Treg, CD8, CD4 T cells, Treg, and NK cells. Okay, those immune response all immunocytes. Some will limit the growing of virus or limit the spreading of virus, or will release their cytokine or interferon gamma to block their replication of RNA. But however, those cytokines or free radical, especially released from neutrophils, they are toxic to the cells, and this may generating a lot of cytokine storm, which may lead in ARDS. That's the main reason cause death or COVID-19 patient for the people with a severe immune response. And second, as I just mentioned before, COVID-2 virus, they rely on the binding of ACE2 receptor and the process their activity and duplicate their genome and the reproduction their little virus in the host cells. So in this behavior, will deplete ACE2 receptor expression, the number on the host cells. As we know, ACE2 is very important converting enzyme. They convert the angiotensin 2, angiotensin 1 into short peptide, angiotensin 1 to 7, angiotensin 1 to 7 to 9. Okay, this is very important to maintain the balance of RAAS. So, imbalance of the RAAS may leading to severe progression of the Sars Cov2 virus infection. Okay, therefore, I would like to get more deeper in the following slide to explain these two major events after infection. Okay, what is the RAS? Okay, that's the full name is a renin angiotensin aldosterone system. Okay, this system is very important to maintain our blood pressure and maintain the fluid volume. Okay, for example, during our dehydration or lower blood pressure, our liver will release a chemical substance, angiotensinogen. This substance will be converted to angiotensin 1 by renin. Renin was released from kidney when it responds to low pressure of blood or a low fluid volume. Angiotensin 1 later on will be converted into angiotensin 2 by ACE. Full name is angiotensin converting enzyme released from lungs. Okay, then angiotensin 1 and angiotensin 2 will regulate a vascular tone and change the size or volume of vein or vessel. Okay, and leading to vessel constriction. Okay, then they will regulate blood pressure. In other way, angiotensin 2 will working on adrenal gland to stimulate aldosterone. This hormone will regulate uptake of water and salt, okay, into the blood flow. Okay, So increase the free the volume. Okay, last RAA system. And ACE2 is a kind of enzyme. Okay, it can convert angiotensin 2 into another peptide. So those are can help. Here's angiotensin. Here's the ACE2. Will convert angiotensin 2, angiotensin 1 into angiotensin 1 to 9, 1 to 7. Okay, and these two peptides will bound to another type of receptor. It's an angiotensin 2 type 2 receptor. Okay, this has the opposite function comparing to angiotensin 2 and the angiotensin 1 bound to the type 1 receptor. You see, this one can increase vessel relaxation, increase the volume, increase the size or vessel, has an anti-proliferative function, and also anti-oxidative stress and anti-fibrotic function. So ACE2 is very, very important. Well, this signaling will reduce pro-inflammatory index. However, after the the angiotensin 1 and angiotensin 2 will deliver opposite function or effect on patient. So you can think about this with imbalance or out of balance of this angiotensin 1, angiotensin 2, and their receptor will cause a lot of disease or side effect in different organs. For example, in the liver will cause oxidative stress and leading to steatosis. In the kidney will cause the fibrosis, inflammation in the lung may cause a severe lung injury or pneumonia in lung. Okay, so this RAS system is very, very important, will impact a lot of different clinical disorders. Keep in mind. So let's look at the COVID-19 virus. They were bound to ACE2 receptor, right? So depleting ACE2, no more ACE2 mediated signaling will process. Most of angiotensin 1 and 2 did not convert to the short peptide. They still maintain angiotensin 2 and bound to type 1 receptor, which make a blood flow, make a vascular tone smaller, okay, and leading to acute lung injury, and also making a vascular permeability increase, which will increase the infiltration of leukocytes, okay, and of course leading to ARDS and pneumonia. And you can see that again. Here's the liver, secrete angiotensin nargin, and convert to by renin into angiotensin 1. Angiotensin 1 will convert to by ACE into angiotensin 2, and these two will bound to type will converted by ACE2 receptor converging enzyme. Okay, and this 1 and 9 will bound to another different receptor, which can help a vasodilation, antioxidant effect, anti-inflammatory effect. However, if angiotensin 1, angiotensin 2 will cause vessel constriction, okay, increased salt absorption, and the endothelial dysfunction. Therefore, there's another option. These inhibitors may be good for treatment of COVID-19 in the patients. So let's look at the impact during the COVID-19 infection. As we know, the entry rely on the ACE2, this enzyme. ACE2 was expressed over the tissue, including the lung, including the liver, including the kidney, in GI, brain, CNS, eye, nose, heart, and blood vessel. So COVID-19 infection is severe, may damage or impairing different tissue, different organs. Some people will lose their they cannot smell anything, right? They don't have the they cannot taste the odors, smell delicious the food. Okay, blur in the eyes. Okay, so diarrhea. So their impacts are huge. Most of the case recently in the Japan has been reported a vertical transmission from mommy to the baby. So it's likely, as a Chinese scientist claim, they found the virus particles in the semen of male patient. Okay. Okay. So when a patient has experienced the symptom of this disease, they are going to send into the ICU or see in the clinical to do the chest X-ray test. And this slide shows a full picture. They leave the radiological evaluation of the acute respiratory stress syndrome over the first week in a 57-year-old male with non-Hodgkin lymphoma and the H1N1 infection. Okay, this case in the figure 8 show the day one during the admission of the clinical. You can see very clean. I'm sorry, very clean the image, and later on they developed a white spot. We call them pulmonary consolidations at the low lobes of lungs here, and over the next 2 or 3 days, rapid deterioration. On the figure C, you can see a white spot, and later on you call them white lung. Okay, this progression is severe. Okay, and you can see normal size. The heart is and the vascular structure. Okay, it's very difficult to for the doctor to do the diagnosis. And there's one major event, edema, occur in the patient's lungs and cause the heart very difficult to breathe in the patient. Well, later on will cause the heart failure in this picture. Okay, and in these slides is very similar to the previous picture. That this is a patient suffering COVID-19, also will develop ARDS. Okay, you can see the progression on day one. The first day register into the hospital, and later on you can see the opacity on the lung. Okay, the white spot here, and day 5, day 6, day 7, day 8, they are you can see a gradual recovery, and you can see more dense and dark lung tissue observed in the chest X-ray film. Okay, and here also use as a CAT scan to analyze the lung tissue. Okay, and here is actually standing histology sample. Okay, here is gathered from the a normal lung with mild alveolar distensions here, and here is the patient developed diffuse alveolar damage. You can see that here. They can turn to very thickness comparing to other normal cells. I mean, between the cell membrane. And here you can see a lot of infiltration of leukocytes in the acute pneumonia of the patients. Here you can see acute pneumonia with the diffuse alveolar damage here. And you see a lot of neutrophils infiltration here. So so you can see during the ARDS, you will see a lot of neutrophils, a lot of white cells will migrate from the vessel into the tissue. Okay, those infiltration will lead in the cytokine storm and cause failure of lung and the death of lung cells. Okay, that's a major reason cause ARDS and cause death of patient. Okay, here I would like to go over the leukocyte adhesion cascade, which is important. The mechanism using adhesion molecules to facilitate activate the cell, leukocytes in the blood flow into the tissue. Okay, there are several adhesion molecules has been studied. And the first type is selective molecules. Another one, integrin molecules. Selective molecules including L-selectin, P-selectin, and the E-selectin. Okay, L-selectin is responsible for capture. L-selectin will bind to L-selectin, will bind to PSGL1 for capturing or tethering. And later on, probably 10 to 15 minutes, the P-selectin will transport from alpha granule or cytoplasm onto the membrane or onto the endothelial cells or expressed on the platelets. Okay, what happened? E-selectin will, P-selectin will bound to PSGL1 and very late antigen. Okay, and NSL1 and the CD44 for facilitating the faster loader on neutrophils. Okay, and by the way, L-selectin also mediated loading or the lymphocytes in the lymph node. Okay, and after 2 or 3 hours, due to the tissue injury, release a lot of different cytokines, for example, and TNF alpha, so will increase the E-selectin molecule expression combined with beta-2 integrin. And those adhesion molecules with the higher affinity with their ligands, okay, those ligands will facilitate slow loader, which can slow down the leukocytes and aggregate in particular size of vessel, which is very close to the trauma or inflammatory sites, and then will turn to a form adhesion. Other antigen will, other adhesion molecules will express on the endothelial cells and also in the white cells. For example, beta-2 and alpha-4 beta-7 integrin or very late antigen. So they can those adhesion molecule will help endothelial cell, the leukocytes, especially neutrophils, to cross over the endothelial cell layer, either through mechanism of paracellular, they migrate between the 2 endothelial cells or directly from one single endothelial cells. which you call them transcellular pathway into the tissue. Okay, until into the tissue, they can find in the pathogen, okay, fragment of pathogen or toxic substance or injury tissue. Okay, they are going to do phagocytosis. They are going to release free radical. They are going to release lipase. They are going to release protein. They are going to release histone protein to minimize the damage or limit the bacteria or pathogen spreading from the tissue to the tissue. And also eventually they are going to do cleanup jobs and doing the repairing in the tissue. Okay, and those process from capturing, from loading to arrest to transmigration, we call them leukocyte adhesion cascade. And this film, they will show you one scene. Okay, you can see that if you are a good surgeon, okay, this image also was taken from the intravitreal microscopy, and the figure was taken after surgical procedure at I think it's 5 minutes after surgical surgery. You can see that there's no leukocyte loading was observed in these two venues. Okay, and it suggests that these surgeons are very good. Did not have induced a lot of inflammatory stimuli or activate a lot of adhesion molecules. So easily it's very clean. Okay, after 10 to 15 minutes, as I just say in the previous slides, P-selectin are activated, okay, expressed on endothelial cells, so recognize PSGL1, their receptor on expressed on white cells. They are very weak affinity, so you can see that they facilitate the leukocytes fast loader. Okay, and you can see that these mice are still alive. You can see the 4 images is moving around. It suggests the mice is still breathing at that time. Because this image was taken from skeletal muscle, so you can see that they are skeletal muscle. So you can see a lot of line here. And furthermore, 3 hours later, we inject TNF. 3 hours later, you can see leukocyte loading pattern was changed. The loading velocity is very small. Okay, so we'll give the leukocytes has a time to stick on the vessel. That eventually maybe they can go and trans endothelial cells and go to the tissue and stick in the tissue to find in their, pathogen or toxic substance in the tissue. Okay, and the figure D is a mice which knock out P-selectin and E-selectin. We lost 2 selectin molecules. The leukocytes are capturing very fast and slow loader. Okay, and however, this virus, these transgenic mice still did not have the symptom at all. Okay, because integrin will help them out to process capturing and leukocytes loading cascade. Okay, it will compensate their function. Okay, here is where we are going to go over the life cycle of neutrophils in tissue. As I just mentioned, leukocytes will express adhesion molecules, for example, CD44, PSGL1, L-selectin. I would like to mention CDF44 is one of my findings when I was a postdoctor. They will recognize P-selectin, E-selectin, media slow loader, and PSGL1, L-selectin is for tethering. PSGL1 will bound to the E-selectin. L-selectin, which mediate leukocyte loading, and later on beta-2 integrin will bound to ICAM, okay, and it will facilitate eventually cross over the tissue. Okay, then go to the neutrophils arrive tissue will start to phagocytosis, clean up the mass in the tissue, and also will release cytokine, which will killing the pathogen. Okay, and in the end of his life, he will release histone protein and the DNA sample, which will making the web will limit pathogen traveling, limit pathogen in the local size, avoid from spreading their pathogen bacteria into other tissue. Okay, the aging or apoptotic neutrophils will be cleaned, will be eaten through apoptosis by macrophage. Okay, when they clean up all the neutrophils in the tissue by macrophage, the cytokine IL-23 expression will decrease. When it decreases, IL-17 cannot get the signaling, then will decrease the secretion of IL-17. Without IL-17, the stroma cell in the bone marrow will decrease production of G-CSF. Without a G-CSF, neutrophils is not going to amplify and or release from the bone marrow. So we'll minimize the number in the blood flow of neutrophils. Okay, this is a whole life. However, if they got an infection, macrophage or dendritic cells will activate, and IL-23 will increase. They will activate IL-17, activate the T cell 17, and will release IL-17 and increase G-CSF, mobilize neutrophils from bone marrow to the blood flow. So they go into the blood flow, they go into the tissue, they fight with pathogen, cleaning out mess. And that's the whole life of neutrophils, okay, in the tissue. Let's see the detail, the web detail, the granule in the neutrophils. Okay, you can see a lot of people working on neutrophils biology. We call them proteomics or human neutrophils. It contains a different adhesion molecule like CD33, CD44, CD47, CD39. Okay, there are a lot of different membrane-bound protein, and in their granule contain different protease. Okay, we call them cytonema. Okay, contain MP9 is a protease, lactoformin. Okay, albumin. Okay, lysosome. Catapacin G, alpha defensin, those enzyme which will target protein, fat, and the lipids. Okay, and also you can see people will study anatomy, which will study their nuclear and neutrophil elastase, histone protein. Okay, those some people believe they has an activity to anti-tumor growing. And some people will study different things. For example, they are going to study their cytokine, what kind of cytokine they do have, what kind of granular protein, what kind of free radical they have. Okay, those material, those compound is strong weapon to kill the pathogen, also kill the host cells if they are they are lost their control. Okay. So after finish the life, the life of a life cycle neutrophils, I would like to go over a little bit immunoresponse during the infection or during the onset of COVID-19 infection. That's a serious one. After infection, right? A virus start to replication, and our immunity will find it. Okay, and the first one is the Ebola macrophage. It's kind of dendritic cells. They will sense it by what? And also some damaged tissue will release a lot of pro-inflammatory cytokines, for example, IL-1, and also pressure or during the replication and assembling a virus, the infected host cell will undergoing a particular pressures and going to cell death because of inflammation. We call them pyropatosis. Okay, at the cell death, the death signaling will activate those macrophage and dendritic cells and start to secrete different cytokine for IL-6, MYC1 alpha, MYC1 beta, and MYC1, and CP1 and IP10, and also can feedback to regulate T cells and make it more activated macrophage. And T cells and B cell lymphocyte will produce a lot of interferon gamma, which is very important cytokine to anti-virus infected host cells. And we mentioned in the beginning, right? The depletion of ACE2 receptor will increase the signaling through the angiotensin 2 and the type 1 receptor. And this signaling will activate NF-κB, which is a very important nucleic transcription factor for immunocytes. Then they will induce a lot of pro-inflammatory cytokines. In the other one, and the other end, angiotensin 2 also can activate the macrophage, turn to activate the macrophage, and activate macrophage can echo previous study, previous slides, will generate the cytokine. This cytokine will combine those cytokines, will generate cytokine storm, and which will leading to development of ARDS in patients. And as we know, in our lung contain a lot of dendritic cells. This particular macrophage we call an alveolar macrophage, okay, which is antigen presenting cells. Besides that, each organs also has particular dendritic cells or macrophage. For example, in the brain, we can see microglia. In the liver, we call them Kupffer cells. In the skin, we call them Langerhans cells. In the spleen, we can Hispanic macrophage. So those cells are very, very important for surveillance purpose. When a bacteria or virus infection, they will intact their antigen and process and present their antigen onto MCH class 1 and MSCH class 2 to tell the immunity T cells and later on B cells to start to have a better adaptive defense. Okay, so the active dendritic cells will go to the lymph node, use them L-selectin adhesion molecules. In this lymph node, they will conjugate with naive T cells and naive B cells. T cells eventually will activate, turn to CD4 positive cell and CD8 positive cell. Depends what kind of MSC class are present, antigen present. Okay, and later on will activate the B cell into plasma cell, and later on will release a lot of antigen into the site or inflammatory. Okay, so now as we mentioned that when during inflammation leakage of venue, a lot of neutrophils will arrive the inflammatory sites. In this case, is epithelial alveolar epithelial cells, and then you can see a lot of macrophage. Now you start to see a lot of B cells, T cells in the site of inflammatory or lung tissue. Okay, they start cross over those barrier from venue, go to the tissue into epithelial and go to airway space. Okay, and start to generate different cytokines into the infected lungs. And those will generate a lot of will cause a lot of cytokine storm. Okay, Let's see this one. Macro outline is very similar, just mentioned before. So well, okay, and the list. So those will, your cytokine and the antibody work together, right? They will clean up all the cells, okay, and get rid of infected get rid of infected the cells and minimize inflammation and lung disease. However, if the patient with a dysfunction of immune response, they cannot shut down the immunocyte infiltration of immunocytes, for example, monocytes, macrophage, and T cells. They are going to secrete a lot of systemic cytokine onto the tissue, onto the lung, and will cause pulmonary or edema, and later on with pneumonia and leading to organ, the lung failure. Okay. So last, I go back again. The cytokine is sometimes like a knife. Sometimes good to kill the bad guy, but also sometimes we're misguiding to kill the good person also. Okay. So let's go over, review all the process after the infection. Okay, then after infection, we're deregulate of the RAS. Okay, during the infection. Okay, during the engagement of ACE2, and damage the endothelial cells, activate the endothelial cells. A lot of huge molecules will upregulate. For example, P-selectin, which will mediate the thromboinflammation, will cause a thrombosis in the liver, so blockage the flow in a small volume. Okay, so you can see that, and furthermore, another one next, which is mentioned, neutrophils will secrete the histone protein and the RNA genetic material, which will eventually block the small volume. Okay, combined with this extracellular coagulation pathway, which blocks circulation, will aggravate the damage of the lung. Okay, ARDS, as you mentioned, a lot of infiltration of leukocytes and generally a lot of cytokines, and eventually will cause the cell damage, tissue damage, and cause the edema in the tissue. Okay, and of course a failure of a lung. However, there another event I didn't mention previously. ARDS patient, if survival will in the later phase will develop the fibrogenesis of would develop fibrosis in the lung. Okay, in other words, they cannot regenerate a good functional lung cells. However, they recruit the epithelial cells, which fibroblasts with no function. Okay, and this will leading to impairing the functional lung. Okay, and a lot of patient survivor, ARDS survivor patient were suffering a lot with very difficulty in breathing. Okay, this data derived from the 87 patient and evaluate and doing the white count to analyze what kind of cell, what kind of leukocytes are correlated to severe or mild COVID-19 disease. Okay, and all 84% they are categorized into three population. The first one with population of decided by their oxygen saturation. Okay, more than 94 we call them mild, moderated between 90 to 94, less than 90 we call them severe, which is suggesting there's a difficulty in the lung function. And another one is a respiratory rate. If the rate is less than 24 per minute, we call it mild. with increase in frequency in breathing between the 24 to 30, we call moderate, and more than 30, we call it severe. Okay, now we'd like to look at the data. The age is less. Let's see the age here. It tells you very important parameters here. Age doesn't matter. Age doesn't matter. Okay, the aging people basically will show more severe symptoms compared to young person. Look at this one. In mild patient has a 30 average age is around 30. Okay, moderate for near 40. Severe is around 57. So it's suggesting aging is one of factor to develop the severe form of COVID-19. Okay, let's see this gender. Okay, here they are male. It's 53, and female is 3rd. This is strange data. Okay, I'm sorry. The 87 male and the 61 female. I'm sorry. Okay, and they are female. They are the mild symptom is 63, 53, and actually there's no sequence. So this disease, the gender, it doesn't play the major role, but the age, yeah, it is. Okay, let's look at the white count. Total white count is 8,600, around that total white count, right? However, the mild is 7,200 is drop in the mild, but the moderate increased 11,000, and the severe form is more than 15,000, so significantly higher. Okay, so it's suggesting that severe form has higher white count in the bloodstream. Okay, this data may correlate to the in histology assessment a lot of infiltration or leukocytes. So it means that the cytokine is out of control. Okay, and the leukocytes was infused from the bone marrow into the bloodstream. Okay, let's see detailed information. The first one, neutrophils, 94. In mild, 59, a little bit drop, but not significant. Moderate and severe is 88, so it's a p-value is less than 0.05. It's suggesting the number of neutrophils is correlated to severeness of the COVID-19 disease. More severe form has more neutrophils in the bloodstream. Lymphocytes, yes, okay, 24.9, but in the mild form, 29.9, there is not significant changes. And 13, 7.58, and p-value is significant. It suggests that lymphocyte number, monocyte number, lymphocyte number are dropped in the severe form of COVID-19 patient blood. Okay, and the monocytes also has reduced the numbers. Okay, and the eosin also reduced the numbers in severe form, and the basal did not change, no significant. Good. And they use another use the ratio lymphocytes over neutrophils over lymphocyte, neutrophils and macrophage. You can see the p-value all significant. It's suggesting that has a higher neutrophils number is kind of prognosis factors. With the higher neutrophils in the bloodstream, in the white count, implies the severity of the COVID-19. Okay, in addition to the age, this also analyzed two kind of patients suffering the diabetes or hypertension. You can see that diabetes patient also has much higher and ratio between the neutrophils and lymphocytes and neutrophils and monocytes. Okay, p-value is less than 0.05. So it's suggesting it's same to the people with the suffer with hypertension. Okay, so it's suggesting in these figures suggesting three kind of people are partially associated with the surveillance of the COVID-19. One is age, another one is the kidney, is a diabetes, the third one is hypertension. Okay. So in the end, I will summarize all the my presentation regarding COVID-19, this disease. Okay. After extended in-host or context, the patient suffering with the SARS CoV2 virus, okay, and will get infection. Some people without the symptoms and later on develop the antibodies in their body. Somebody has with the low virus titer and will express mild symptoms, okay, and then their normal immune response will come in and take over and killing all the virus or limit all the virus and clean up all the infected lung cells, okay, and go to recover. However, some people, for example, aging or immunocompromised patient or diabetes patient, okay, their immunity will react in different response. Okay, they could not normally function their immune system. They could not regularly infiltration of neutrophils. They will secrete a lot of cytokine in their lung tissue. Okay, cause the cytokine storm, and eventually cause damage or lung tissue with the edema on the lung tissue, and people will reach the ICU. Then other therapeutic regimen need to apply into the patient. Okay, if they cannot stop this progression, the people will eventually die. Okay, and look at the data of this on blood on white count. You can see that in the peripheral blood COVID-19 patient, the leukocyte neutrophils number will increase, the macrophage will increase, and but however the lymphocytes number will decrease. Okay, how about in their tissue? They will develop nets, okay, and the thrombosis, and the limit of providing oxygen or nutrients into the lung cells. Again, the T cells and NK cell will decrease. Okay, is not not able to regulate their cytokine production in the neutrophils or other cells. So has the different thrombosis and coagulation occurs in the lung and cause the cell death, develop the ADRS eventually. Okay, any slide just tell you thromboinflammation, thrombosis also another factor to the COVID-19 patient. However, it tell you another route for treatments. Okay, give the anti-thrombosis drug made it good for patient to recover faster. Okay, here is the drug for treatment COVID-19. Okay, we can use the antibody block the binding between the ACE2 receptor and the S1S protein. Okay, and also we can use the proteins inhibitors, for example, chemostat, to block the functional protease TMPRSS2. Okay, reduce the fusion between membrane and the virus. Okay, another one after endocytosis, because in this environment, in the vesicle are very pH value is very low, so we can apply for hydrochloroquine, which has increased the pH value in the endosome, and those proteases will lose their function, they lose their bioactivity, so they cannot disassemble in those protein, for example, M protein, E protein, amyloid protein. So what happened? They cannot release their messenger RNA. They not release their RNA, so they are not going to process transcription or translation later on. So that's another way for the treatments. And second one, we can use the inhibitors to block translation or inhibit block transcription. Okay, and for example, lopinava and remdesivir, okay, they can block their transcription. And later on, we can use the anti-inflammatory inhibitors or cartel drug to block the IL-6. This tocilizumab is an antibodies against the IL-6. Okay, block an IL-6 receptor, so block their signaling and reduce the cytokine storm. Okay, that's a strategy for treatment of patient with the COVID-19 in the ICU. Okay. Here is another way. I just mentioned, we can use the drug targeting to the life cycle. We can use the drug to block the anti-thrombosis, and another one a drug to block the activation of complement. You can see that during the infection, antibody will activate the complements. As we know, complements is a kind of protease in the serum, eventually will destroy integrity or infect the host cells. However, if we cannot regulate this protein, it may damage our normal cells also. So we can use the drug to target complements, maybe increase the will reduce the chance of patient to get to to develop the ARDS in their lung injury from pneumonia. Okay. And later in the last part, we are going over the drug development, especially in the vaccine. Okay, as we know, the development of vaccine is a long way in the pharmaceutical industry. Okay, and it may take 15 years, and then you will spend 5 years or 4 years in the lab, find the molecules, doing the screen, do the affinity assessment. Then later on, you are going to stay probably 5 years in clinical trial, phase 1, phase 2, and later on go to the marketing. It's a long way to go. However, you guys will ask, how come less than 1 year with the virus, our vaccine available in the market, and people start to inject those vaccine? Okay, the reason why, because we got a experience of SARS virus and also MERS virus, okay, and the Ebola virus, okay, and their RNA homology very similar. The infectious life cycle is very similar, so it's much easier to speed up the lab work. Okay, and another thing, they use a different strategy because the methodology changes. Okay, and also because the people, so they save a lot of time in the lab work. And in the clinical trial, we know we have a lot of patients. We can process all the clinical trial 1, 2, 3 phase at the same times. Okay, we have different patients. We have different individual doing the safety issue, doing the therapeutic assessment. Okay, so in the 1 year, we have a different vaccine from different company available for market. Okay, we can the way we make a vaccine, we can use the DNA virus, Okay, we can use messenger RNA. We can use the core protein. Okay, and we use the dead virus. We use the loss functional virus. We can use the core protein. Okay, use this strategy to make our vaccine to active to wake up our immune system in our patient. Okay, so far there are 6 vaccine for treatment and for prevention of COVID-19 treatment or prevention are available. Okay, here's most of the case I'm making from the messenger RNA, some from the virus protein directly, some from messenger RNA, and their price are probably around per dose, probably around $5 to $20. Okay, depends what kind of drug, what company you use. Okay, and however, Johnson has been suggested is best one because they only one dose that's good enough for giving the immunity. Okay, in the end, I would like to share you the campus life in TMU. TMU is located in the Taipei and just 10 minutes walk away from the famous building Taipei 101, which is here. And then you can see, and here's the TMU affiliated hospital. Okay, just 2 minutes away from the campus. And this is the picture was taken in the campus. You see a lot of happy Indonesia students. Okay, I forgot what kind of event they are celebrating. Okay, so far there's 327 international students and 93 from Indonesia. Among them, 35 students are pursuing their PhD, 18 for master degree. Okay, so it's a lot of Indonesia students study in TMU currently, and as I just mentioned, TMU is very close to Taiwan Building 101, and it is a good location to observe the firework during the during the New Year. People can climb the hill. We call them Xiangshan Hill, and you got a very good spot to take a picture for night scene or take a firework during the New Year Eve. Here is the annual event, party event. Okay, end of year annual party event. You can see a lot of foreign students which register in our program, and we have the party with the faculty, okay, and the chair and director. And the Taiwan University has only 60 years. Was built around 60 years ago, and right now he has a very good reputation, and with around 300 to 350 world ranking. Okay, on the 2021, you can see our progress. Of 2020, we are 300 to 40, and right now we improve. Okay, and recently we got ranking 18 in the Good Health and the Well-being University. Okay, and here's some key statistics in our school, and the number of students per staff is 9.8, and our international student probably 10%. Most of them are postgraduate student. I mean, a graduate student. And student ratio of female to male is 58 versus 42, and number of FET students is more than 6,000. Okay. And in the end, thank you very much for your listen. And here is the end of course of my seminar course, and you can see people from different regions, from Indonesia, from Vietnam, from Mongolia, from the United States. Okay, Actually, I had to mention these girls. Uh, I forgot her name. What's her name? Ufa. Okay, I'm sorry, Ufa. She's coming back for a master degree. Okay. Again, thank you very much for your listen.